practical consideration. Oh, sorry, I don't know.
I think it's okay. Just keep going. It was
Yeah.
recording for the talk.
So certainly, just most of my time to discuss some practical issues we need to make in HCC treatment that include patient selection. When do we start systemic therapy for BCLC B patients, whether we can treat Child's Pugh B patients safely, and starting doses of TKIs in patients. So as you all know that hepatocellular carcinoma is relatively uncommon in Canada. Each year, about 1,600 patients will die of HCC, but it is one of the few cancers who actually has an increase in mortality rate. And also, Toronto happens to be a hotspot for liver cancer. And this is because 90% of HCC occurs in the setting of chronic liver disease due to hepatitis, alcohol, or NASH. So in Toronto, the incidence of HCC is 9 times higher than other areas of Ontario. So HCC may be a relatively uncommon disease in other areas, but in Toronto, and as Anthony mentioned before, that we see a lot of patients with HCC. This is recent data from the American Cancer Society. Again, a similar trend that there is an increase in mortality rate for HCC. So it is projected that by 2040, HCC mortality will be the third most common cancer-related deaths, actually more than colorectal cancer or even breast cancer. For those of you who do not treat HCC, I just want to point out that the TMN staging system is not commonly used in HCC. There are several other staging systems. The most commonly used staging system is this BCLC system, and which take into consideration of tumor burdens, that is the number, size, vascular invasion, extrahepatic spread, but not only the tumor burden, also patient's liver function and the performance status. So systemic therapy is usually indicated for patients with advanced stage or BCLC-C patient. Now, systemic therapy for advanced hepatocellular carcinoma really started in 2007 or 2008. That's when the SHARP study was published. So in this trial, patients were randomized to sorafenib or placebo, and as you can see that there is increased overall survival in sorafenib treated patients. So this is really the first time in a randomized study systemic therapy was shown to improve survival. So it took us another 10 years before a second drug, in this case, lenvatinib, was shown to be non-inferior to sorafenib in the first-line setting. However, in the last 2-3 years, results are coming fast and furious. So there are several first-line study results has been presented. So the first one, or the one we're mostly familiar with, is IMbrave 150 study, which randomized patients to atezo and bevacizumab to or sorafenib. It is important to point out that 40% of patients in the study has macrovascular invasion, and because of the high dose of bevacizumab used in the study, patients with untreated or incompletely treated varices were excluded. It showed that overall survival improved from 13.4 months with sorafenib to 19.2 months with atezo-bev. Now, the second phase 3 study is a Hemaria study, which was presented earlier this year. And in this study, patients will randomize to dual inhibition with durvalumab and chimilizumab, which is an anti-CTLA4 antibody versus sorafenib again. And again, there is a survival benefit from 13.8 months with sorafenib to 16.4 months with the dual inhibition. In the recent ESMO, there's a couple other studies were presented. So the LIP-02 study was a highly anticipated large study, and it randomized patients to lenvatinib plus pembro versus lenvatinib alone. So although it showed improvement in overall survival from 19 months with lenvatinib to 21.2 months with the combination, the p-value was 0.0227, which actually is higher than the superiority threshold. So this study, in fact, is a negative study to the disappointment of many of us. Another study from mostly from China was presented as well. So this randomized patients to anti-PD-L1 antibody and anti-VEGF TKI from China versus sorafenib. Again, it showed improvement of overall survival from 15.2 months with sorafenib to 22.1 months with a combination. So if we look at those data together, there's a couple of noticeable findings. So first of all, you can see that the overall survival now is reported to be 21.2 months and 22.1 months. So this is the first time we are seeing over 20 months overall survival from randomized studies for hepatocellular carcinoma. Secondly, the overall response rate now is reported to be 25% to 30% rather than the 10% with lenvatinib or less than 5% with sorafenib. Now, because of this high response rate, now we can think about using those combinations in earlier disease settings, such as in the adjuvant or neoadjuvant setting. So there have been several adjuvant studies, and those studies listed in this table have all completed accrual. So hopefully that we'll have readout from those studies soon. There's a few early phase studies looking at neoadjuvant setting, for example, the pembro and the lenvatinib prior to liver transplant. So those studies are still early, and the results are going to take a few years to be available. And finally, there are quite a few studies looking at combination plus TACE. And again, a few of those studies, such as Amyloid-1 and Checkmate 74W, have completed accrual, and hopefully we'll see the results from those studies soon. So with all those agents, it will take us some time to work out the optimal sequence of using those drugs in the clinical setting. So this is an algorithm proposed by a Canadian expert panel and published last year. And already you can see that it needed modification, right? So that we may consider durva plus tremi in patients who have contraindications to bevacizumab. Now, another potential exciting modality is radiation in those patients. So ITOG 1112 is a randomized study. Patients are assigned to sorafenib or SBIT followed by sorafenib. And this study has very heavy involvement from Canadian investigators. So the overall PI is Dr. Laura Dawson from UHN. Dr. Jennifer Knox is one of the two medical oncology co-leads, and Canadian centers enrolled over 50% patients in this study. And I believe that Dr. Dawson is presenting results from this study in the ASTRO plenary session in a week or two. And if positive, obviously, this gives us another modality to use in advanced HCC. Now, with all those options, so in clinically, how do we decide? Right? So that so this is probably the most controversial topic right now, and you may know that early last year this paper was published suggesting that at least preclinically viral-related HCC and non-viral related HCC develop along different pathways, and as a result of that, patients with non-alcoholic fatty liver disease associated HCC may not respond to immunotherapy as well as viral-related HCC. And there's also a meta-analysis published in that article, and again, confirming that non-viral related HCC does not respond to immunotherapy well. However, in the bottom table, you can see the most recently updated data from IMbrave 150, showing that non-viral related HCC actually benefited, did very well with sorafenib. The median overall survival is 18.1 months with sorafenib alone. So this may be why the benefit seen with IO are not as obvious compared to viral related HCC in that study. So, and this paper in Nature Medicine earlier this year looked at some correlative studies from IMbrave 150. And one of the biomarkers they looked at is PD-L1 positivity. As you can see, that as in other solid tumors, that there seems to be a gradient that with more PD-L1 positivity, that the benefit from IO treatment increases. But it is also important to note that only about 60% patients with HCC has PD-L1 expression, and only about 10% of them will have a PD-L1 over 10%. So right now, that we still do not have reliable or validated biomarkers to help us select a patient for IO or TKI, and the decision is still a clinical decision. As we kind of mentioned before, that systemic therapy is mostly indicated for patients with BCLC advanced stage or stage C, but for intermediate stage or stage B patients, the main treatment is TACE. However, TACE is still a palliative treatment. So how do we decide on the transition from TACE to systemic therapy? So we know that there's patients who are more likely to respond to treatment and to TACE, and those patients are usually have limited disease burden. So they may have a solitary lesion, they may have limited multifocal disease, they have no vascular invasion or extrahepatic spread, and they have preserved liver function. But is there any way for us to predict who is not going to respond to TACE or who is going to become refractory to TACE? There's obviously no randomized studies to support those decisions, but there are expert panels and consensuses. So this is from the Asian Pacific consensus. So they divide patients into 3 groups that who are unlikely to benefit from TACE. So the first group is the patients who are unlikely to respond to TACE from the beginning. So those are generally patients with massive infiltrative disease, high disease burden. The second group is patients who are likely to develop failure with repeat TACE. So those are patients who, again, has a somewhat higher disease burden, and they used the up to 7 criteria. So again, just to remind you, up to 7 criteria was originally developed to evaluate outcomes following liver transplant. It is just the total sum of diameter of the largest lesion and the total number of lesions seen. So if you have 1 lesion, which is 6 centimeters in size, then you have 1 plus 6 is 7, right? And if you have 4 lesions and the largest being 3 centimeters, it's 4 plus 3, again, it's equals 7. As you can see from that graph, that so the pink line is for patients who meet Milan criteria after transplant, so the survival is very good. The blue line is for patients who are beyond the Milan criteria, but not exceeding the up to 7 criteria. Again, that group of patients has a very good survival. The green line is for patients who are beyond Milan and beyond up to 7 criteria, and this group of patients seems to had the worst outcome after liver transplant. And lastly, that group of patients whose liver function may deteriorate after TACE. So again, those patients are with a somewhat higher disease burden over the up to 7 criteria, or they start with a relatively poor liver function, such as modified LB grade 2B. So why should we not continue with TACE? And this is because that by doing so, we may potentially harm patients. So there's really, again, no good randomized study to support our decision making, but this real world TACE experience is probably the best evidence we have right now. And so this database was initially set up to try to compare the difference between patients who were started on systemic therapy when they become refractory to TACE and those who did not immediately start on systemic therapy after TACE failure. There's about 1,000 patients included in this database, and there's actually some very interesting findings. So overall, it appears that about 40% patients would have contraindications to TACE worldwide. Even when you look at the EU and Canada, about 40% patients may have contraindications to TACE. You may argue that the number one reason is that the patients has a poor performance status. It's a soft indicator, but even in EU and Canada, we can see that patients with BCLC C or D, up to 13% of them are still being TACEd, and patients with extrahepatic spread are still being TACEd, and patients with vascular invasion are still being TACEd. in the real world setting. And patients about 30% patients liver function will deteriorate after TACE. So this looked at the response after each TACE. As you can see, that just like chemotherapy, that the more TACE you do, the more likely that the disease will progress, the less likely that you will have a response. So after about, on the fourth TACE, only about 25% patients will have complete or partial response, and 27% patients will have progressive disease. So when you look at the survival, and after you match in patient for their characteristics, you can see that the survival in patients who started systemic therapy immediately when they become TACE refractory is much better compared to those who waited after they become TACE refractory. So again, emphasize the importance to start those patients on systemic therapy early and not wait. So this is a subgroup analysis from the IMbrave 150 study again. And as you can see that in the BCLC-B patients may actually derive more benefit from systemic therapy compared to the C patients. Their survival is longer, they have a higher response rate. So this is why that we need to stop over-TACE our patient. Now, it is also common that we say that we are dealing with two diseases, not just one disease. One is HCC, and the other, sometimes even more complex issue is what to do with their cirrhosis and the complications from their cirrhosis. For example, from the social aspect, patients may be less compliant with oral medications. They may lack social support, and from the cirrhosis, they may have portal hypertension leading to thrombocytopenia. They may have ascites and varices that needed other expertise to manage. And we also know that liver function in some patients actually determines their outcome. So this graph shows data from some Strosberg study, and as you can see that in patients with Child-Pugh C, that their median overall survival is only 2 months compared to 10.3 months in those with a Child-Pugh A liver function. So right now, that the most commonly used measure for liver function is still Child-Pugh score. Recently, the ALB score was, or ALB grade was proposed as a better measure for liver function. So the ALB grade only looked at the bilirubin and albumin, as you can see from this formula, and the patients were then divided into grade 1, 2, and 3. So as you can see that, so in this graph, all those patients are with Child-Pugh A and BCLC-C. ALB score seems to be able to separate those patients further, and ALB grade 1 patients has better survival compared to those with grade 2 patients. But the one disadvantage of the ALB score is that the majority of those patients are in the grade 1 or grade 2 region, and over 50% are grade 2. So this is why a few years ago, a modification was proposed that patients are now being divided into grade 2A and grade 2B. So in theory, that AB grade has several advantages compared to the Child-Pugh score. For example, that it was derived from over 600 patients and validated in over 1,000 patients. Child-Pugh score was developed in 35 patients with cirrhosis and undergoing hepatectomy, and it was designed to predict mortality rate after their surgery. Okay, so RB score is more objective. So you have bilirubin and albumin; those are measured. You do not have to have a subjective assessment, such as the degree of ascites and whether a patient has encephalopathy, right? But as you can see from that formula, that AB grade is actually not easy to calculate. Okay. So right now, that Child-Pugh is still sort of ingrained in our psyche, I guess, just like body surface area or weight-based dosing. And it seems that it is very difficult for medical oncologists to unlearn some concepts, despite the advantages of this new concepts. Another common problem we encounter clinically is whether patients with Child-Pugh B cirrhosis or liver function should be treated, and mostly with TKIs, sorafenib or lenvatinib. Again, the only randomized phase 3 study has to be terminated early because of poor accrual. So we do not really have phase 3 data. All we have is real-world data. So this is real-world data from Japan looking at lenvatinib. And so again, you can see that no matter how you look at the liver function, patients with better liver function, Child-Pugh A or LB1, 2A patients has better survival compared to those with Child-Pugh B or 2B and 3 patients. Looking at the toxicity, it seems that although the overall incidence rate is not different, but patients with Child-Pugh B have increased incidence of decreased appetite, diarrhea, encephalopathy, and vomiting. So that we do need to take toxicity into consideration. How about sorafenib? And so this is a meta-analysis done by Marie and Jennifer and Ethan and Mia. Again, it shows that Child-Pugh patients do worse compared to Child-A patients. But in this study, because it's literature-based, they were not able to show any difference in terms of treatment discontinuation or related deaths in Child-Pugh B patients compared to A patients. In the Checkmate 040 study, there is a group of patients with Child-Pugh B7 or 8, and compared to those with Child-Pugh A patients, the response rate and treatment-related adverse events seems to be similar. So at least it seems that immune checkpoint inhibitors are better tolerated in those patients. So this is recently published data looking at cabozantinib in Child-Pugh B patients. So this is from the Celestial study. And although all patients at the beginning of the study have Child-Pugh A liver function, but by week 8, about 10% of patients has deteriorated to Child-Pugh B. So looking at the B group and the overall population, there does not seem to be any difference in terms of adverse event, discontinuation or dose reduction. And the average dose for those patients are similar to the overall population as well. But it is interesting to see that patients with Child-Pugh actually may still benefit from treatment, that the overall survival is 8.5 months compared to 3.8 months with placebo. Now, clinically, that when we start patients on treatment, especially TKIs, there's always a concern that whether they could tolerate the recommended dose. So we may elect to start some patients at a reduced dose. Then the concern then is whether those patients will still benefit from the treatment. So again, there's no randomized study, but the real-world data seems to show that starting patients on a reduced dose for various reasons may be reasonable. So this is the Canadian data looking at lenvatinib. So 173 patients was treated in the first-line setting, and half and half, so 54% started on a full dose, and 46 with a reduced dose. It does seem that full dose have a high incidence of hypertension and nausea, but fatigue and diarrhea seems to be similar. Now, it is really reassuring to see those survival curves in that reduced dose patients do just as well as patients who are studied on the full dose. In terms of sorafenib, this is the data from the US, and looking at the percentage of patients who started on the full dose or reduced dose with each year. So as I said before, that sorafenib became available in 2007. So in that year, 80% patients were started with a full dose, and 20% patients started with a reduced dose. But over time, you can see that less and less patients got started on a full dose, and more patients got started on a low reduced dose. So by 2014, the percentage is essentially equal. So I want to close my talk by mentioning that HCC sometimes may have unexpected disease cause. For example, in the literature, there's reported cases of spontaneous regression. And so this regression usually occurs after some systemic inflammatory response or patient experienced tumor hypoxia. So a patient of mine who had tumor rupture and required hepatic artery embolization to control the bleeding actually had his disease regressed over time, and then eventually his disease totally disappeared, so that he is now 5 years post that event without any evidence of recurrence. So it is important for us to recognize those rare phenomena, and so that we could not overtreat those patients. So with that, I'll stop, and thank you again for the opportunity today.
Thank you so much.